Why is suturing education important? Many women in the United States have perineal tears, and if we are not properly recognizing or repairing those tears, there's going to be lots of short-term, long-term complications. I want to go over the core statistics that are present in the United States. The prevalence of perineal trauma occurs in about 70 to 90% of births, 60 to 70% of those women requiring some degree of suturing. The episiotomy rate varies greatly depending on if you're serving a low-risk population that's had lots of babies before versus a high-risk population versus a Somalian population that has female mutilation and additional scarring. I can tell you lots of stories of, in 15 years, I did 2 episiotomies and then helping out at a high Somalian hospital busy volume. In 8 months, I did 15 episiotomies and actually my first double episiotomy because of the significant scar tissue. So it's really important. There's a wide variation of these statistics based on the population you serve, high risk, low risk, and the cultural norms. The incidence of severe tears, obstetrical, anal, sphinctal injuries can occur. It varies greatly. I would say 3 to 6% is pretty accurate for first babies and then lower when you've had babies before. There are things you can't control that impact that, the fast descent, the trauma the mother has had in the past, history of multiple episiotomies, scar tissue, etc. But the problem I really want to stress to you guys is 20 to 40% of these complicated tears, if you miss them, have significant links with fetal incontinence and long-term complications. Short-term complications, up to 90% of women have immediate postpartum period pains, the wound complications, the risks, the skin breakdown, the healing process being impaired is about 5 to 10% of the population. If you have poor suturing techniques, that's going to increase the risk of pain, the prolonging the healing time, and the need for interventions in the future, potentially surgery from the complications and the not properly putting the muscles in the tissue back together, cosmetically or functionally. Long-term morbidity, the biggest one that people complain about is fetal incontinence. If you have a rectal tear and you miss it and you don't get the proper muscles together, 30 to 50% of those women have long-term fetal incontinence and serious surgery issues and prolonged issues. So we do not want to miss that, especially as a midwife. Pain with sex is reported in 20 to 40% of women postpartum. It's higher with improper repairs and recognition of tears. Pelvic organ prolapse increases with poor floor injury repair and inadequate recognition. Chronic perineal pain is at about 10% of the cases because of the nerve damage and the improper suturing or too much suturing or missing things in nerve damage. Education is critical. I can't stress this enough. It improves the detection rate, the proper classifications. It enhances the repair quality, boosts the provider confidence in the autonomy, patient satisfaction, reduces maternal morbidity. It has short-term and long-term impacts of not being able to recognize and not being able to repair. You want to improve the detection and classification. Up to 33% of third and fourth degree tears go undetected and misclassified due to anatomical knowledge gaps, increasing that risk greatly of incontinence and fistulas. Enhance the repair quality and safety. Poor suturing causes wound breakdown, infections. Suturing removal needs training, reduces that by doing hands-on practice while using techniques like continuous locking. Reducing maternal morbidity. Severe tears impact 4% of birth. Skilled repairs prevent long-term pelvic floor dysfunction, pain during sex, and depression. As a midwife, I am overly cautious to transfer for a home birth center to get further evaluated if I'm not sure if the rectal sphincter is involved. I when I'm on a laborious, busy hospital unit, I will grab the obstetrician just to have them glance. My ego will never be hurt by confirming 110% that it's not partially through the sphincter. There's not any muscles that I missed. That's not part of my scope and skills and training to repair for that mother. Her long-term incontinence risk and fistula complications isn't worth me not seeing it very often and being able to recognize partially or completely through that sphincter. And you should feel the same comfortability. Protecting the long-term pelvic floor function, perineum plays a key role in pelvic support and continence. Inadequate repairs disrupt that structural integrity greatly. You can have increased risk of pelvic organ prolapse, chronic pelvic pain, urinary and bowel dysfunctions. You can have rectoceles, cystoceles, and it may not be the first few years. I give people the example, my first son 16 years ago was 10 pounds, and I think with my sutures breaking down and my personal history of lichen sclerosis, I had some not the greatest process with healing with him. I didn't need stitches with my other two children, but now 16 years later, I'm actively working on pelvic floor surgery, and I think a good part contributes to the inadequate suturing and the complications that occurred with my own birth. So I really think it's important, not just for our own lives, but for all the families we serve. We're not thinking when we're doing suturing just about the short term. Does it look right? Does it look pretty? How is the pain going to be the next few days? You need to be thinking about the next 15, 20, 30 years of this pelvic floor integrity for this woman. Preserving the sexual health and quality of life. Poorly repaired perineal trauma can lead to painful sex, scar-related discomfort. I think every person during and after birth should have pelvic floor physical therapy. They're absolutely phenomenal. They can help with that muscle tone and strength and help break down that scar tissue and help with the healing process. But very few insurances pay for it, so it's definitely a challenge. You want to do a lot of education to help reduce the incidence of pain during sex and make sure they understand the resources available to them and that what's normal and what's not. Enhancing the patient experience, less pain, better healing process. A lot of it is perception. So being able to be open, clear communication, comfortable, feel confident with your repair. It will really contribute to a positive birth experience, postpartum recovery, and the overall feeling of, yes, I tore, but I know that the midwife, the care provider, did everything they could to repair my bottom. I've seen it so many times, even just if it's not functional. She's had 3, 4 babies before, and now her labia tore this time. And then there's a lot of fear with cosmetic, or it wasn't repaired well the second baby, and now it's their third, and they're wanting some reconstruction while you're doing the repair and fix things from that last prior birth while you're doing the repair of this one. So there's definitely a lot of cosmetic insecurities and the overall pelvic floor that needs to be kept, and we need to think about her and how she perceives her perineal area short term. We want to reduce clinical errors and the variability in care. I have been a practicing midwife for now 16 years, and half of that has been traveling all over the country and seeing with 15 different state licenses and a traveling midwife. I've seen so many walks of life, good and bad, and I've been very blessed to pull the gems from every place I go to and make sure that we're promoting training. I do a lot of residents and a lot of midwifery students training, and we want to get to the core basics of that. Everybody's got consistent themes of evidence-based. You want to decrease healthcare costs and resource use. The fewer complications means the less readmissions, less complications, less need for surgeries, resuturing, pelvic floor disorders. You want to reduce your legal risk. I can tell you of a few cases that when I went to conferences, they've discussed $1 million cases, particularly in tiny little birth centers, because they missed a third degree and she had years and years of complications of fetal incontinence because of that fetal incontinence and multiple surgeries. And there's lawsuits. If the particular thing, it's harder with legal of pain perception and those vague complications that could be for multiple different things. But when you miss a 3rd degree, 4th degree laceration and you repair it and you do not put the rectal sphincter and you do not put those muscles together correctly, you are going to have significant long-term complications for that woman and her family and a risk of litigation. Build proper provider confidence and competence. You want to do multiple hands-on trainings. You want to do them continually. There's data for a lot of hands-on trainings, like within 3 to 6 months, it's not as fresh, it's not as strong. And that has to do with postpartum hemorrhages, shoulder dystocias, suturing. It's all the same. If you don't use certain techniques and skills and training very often, you lose them. And so you want to make sure it's part of your core regular competencies as a group, as a team, keeping up with the data and the evidence, just like you do every other emergency standard with support into interdisciplinary care standards. This is just as relevant for OBs, midwives, family practice physicians, and trainees. We want consistent, standardized education, and we want to be able to openly and respectfully understand each other's skills and strengths. Like as a midwife, I don't want to feel the least bit guilty that I'm bothering my collaborating physician and making me feel that I'm incompetent because I'm asking for assistance and recommendations and a second hand during a repair, a complicated sulcal tear, unsure if it's a 3rd degree laceration. You want to be able to feel comfortable, especially for independent out of hospital midwives. Like you don't want to be harassed and feel like you're doing the best thing for the patient when you do a transfer because it's a complicated repair that you want them to do with the equipment and the lighting and the additional pain management resources they have at the hospital that you just don't have it in the home and birth center setting. This contributes to a greater, broader maternal health outcome. We want to really help moms in that immediate postpartum period. If she doesn't feel good, she's in pain, she's having complications from her sutures or from the lack of sutures when there should have been some. It will affect breastfeeding, it'll affect bonding, it'll affect depression, anxiety. It has a ripple effect. I've even met a few home birth midwives that don't even look at their bottom after they have a baby, and it just absolutely blows my mind. They could have every low risk situation possible, and I've just been blown away at the amount of tears that occurred when they didn't have any of the risk factors. And so we have to look at perineums after delivery. We have to know confidently the muscles, the anatomy, the categories, and the proper ways to repair and the proper ways to get our colleagues involved, because it's only going to improve short-term and long-term outcomes for our moms and babies. As an overall summary, perineal suturing education is not just a procedural skill. It's the foundation to patient safety, proper recovery, and long-term quality of life for that pelvic floor. You want to have consistent, high-quality training that leads to better outcomes at every stage of our care, not just during prenatal visits, not just during birth, but that immediate postpartum period. I think in Europe, especially with Guiding Zone, they have done an amazing job of really getting perineal suturing, perineal floor support in the immediate postpartum and long term. They figured it out. They've got pelvic floor clinics, they've got suturing, they've got standardization that blows what we have here in the US out of the water. And I would like to bring that high quality of standards of care and expectations to the United States and the families we serve.